All right, so I think we're pretty much set. If everybody can hear me, we have Russell. Oh, sorry. Get my microphone on. So let's tuck it in somewhere here. What's happening? All right, so it's 11 o'clock, and so we're going ahead with our second episode of this webinar series I call Surviving COVID-19. It's born out of a desire to step up my advocacy on COVID-19 so I could reach a lot more people with a message that COVID-19 is indeed real and why everybody needs to observe the protocols as we have been advised, especially wearing a face mask, social distancing, washing of hands regularly with soap and running water, as well as regular use of hand sanitizer. Now, in the very first episode last week, one thing that was said, which I think everyone should live by, is that assume that everyone you encounter, everyone at all you encounter out there in public has COVID-19, which they could pass on to you. So you treat them accordingly. This doesn't mean that you should stigmatize them. And indeed, that can be called stigmatization. As we have all been advised, keep a safe distance and wear your mask or keep your mask on. It is when we assume that some of the people we encounter in public or we encounter anywhere cannot have COVID-19, that's when we let our guard down, and that's when we become vulnerable, as we're realizing happens in the workplace. Now, thing is, you can be as careful as you can be. You can be that careful. But that 1 minute you let your guard down, could be that minute you become exposed. And yes, though many people recover from COVID-19, some are not so lucky and they die. And because you're in no position to tell whether you will die or you will survive, don't take chances. We've also been told that though you may recover from COVID-19, it could do irreparable damage. to your internal organs that may eventually cost you a lot of money in medical bills and ultimately your life. So do stay safe. It has been said that it is probably because people let their guard down when they're around others they are familiar with, that we're having workplaces becoming hotspots for COVID-19 spread. And that is why the conversation today is focusing on controlling the spread in the workplace. And to help us do justice to this topic, we have Noella Birigimana from Rwanda, where she serves as a strategic advisor at Rwanda Biomedical Center. That's Rwanda's National Health Implementation Agency, which leads national health implementation programs, including the COVID-19 response. And Noella, hello, Noella.
Hello, everyone. It's an absolute pleasure to be joining this conversation. Thank you for having me.
Thank you too for being part of this. And Dr. Kaba Akoriyea from Ghana, he's a consultant neurosurgeon and public health physician. He's a director of the Institutional Care Division of Ghana Health Service and COVID-19 Case Management Lead and Deputy National Case Management Coordinator. Hello, Dr. Kaba.
It's an absolute privilege to be with everyone here this morning. Thank you.
Great to have you too. Now, Dr. Hazel, BERRARD, AMUAH, an HR and business strategy expert and regional director for Fan Milk West Africa, is also with us. Hello, Dr. Hazel.
Hello, Israel. Good to see you.
Great. Yeah, great to have you here. Now, we also have from Nigeria, Adebayo, AKINLOYE is a director of Global Talent Solutions and author of Talent Management Agenda in the post-COVID-19 world. Hello, Ade.
Hello, everyone. It's my pleasure to be joining the discussion.
All right. Now, our other very important guest is Russell Banful, who runs an advertising agency in Ghana called Brandflow Limited. He is with us primarily because he's battled COVID-19 and survived, and has been gracious enough to share his story with the rest of the world. Of course, being the MD of an advertising agency, he's also well placed to talk about dealing with the pandemic in a corporate environment. And we need to salute people like him, because it's not an easy thing to come up publicly to talk about your COVID-19 status because of the stigma. So thank you once again, Russell, and also for what you're doing to support the frontline health workers since your discharge. Also joining us in this conversation as a co-host is my wife, Louisa Laye, who is head of business strategy and research at one of the largest banks in Ghana. She has an MBA in HR, but is first and foremost an ACCO fellow. Hello, Louisa.
Hi, everyone. Hello, Israel. Nice to be here.
All right. So welcome to all of you. And to those of you watching us online, you please like my page and subscribe to the YouTube channel, because I have a lot more coming your way. Let's start with Russell. Now, how are you doing, Russell, post-recovery from COVID-19?
Thank you. Once again, thank you for the opportunity to share my experience. Israel, I'm doing well. I'm feeling awesome, strong. And I think that's gradually I've got where my energy was prior to the attack.
All right. How do you think you caught the virus?
That's one thing that is difficult to tell, and it appears it hasn't been only me. Quite a number of people that I met at the hospital did say same. No, they couldn't identify or figure out where they caught or they contracted it. It's strange. I mean, in my case, I was out of the country, came back somewhere around the 16th of March. 2-3 weeks after that, I did a test. It was negative, by which time I'd also closed down my office because generally the lockdown had affected our line of operation so much. So pretty much I've been home since March the 16th. Occasionally, and I would probably step out for a one-on-one meeting with a client or so. But rarely would I go out. There was, I think, 1 or 2 occasions that I met a group of friends, which were not more than even 10 or 15, I think so. But it's really difficult to tell where I contracted it.
But at least you can say that there were instances where you probably may have exposed yourself or become exposed to the virus. Or...
Well, you can easily be exposed in so many ways. I mean, you can mistakenly even touch something that is infected. Could be the stair rails or some door, or I mean, so even though we maintain the protocol, I keep saying that sometimes you can go off guard and mistakenly touch something that is infected that you do not know. It could even be a door in your own house, or the gates at your house. Maybe somebody probably lean on it, the person is infected. It's tricky. I mean, so sometimes I keep on saying that it's just by the grace of God that some people are lucky that they don't get infected. But I was one of the few people who was very particular about the protocol. But yet, it happened. I met someone who had become a friend of mine at the hospital who was even paranoid when it comes to keeping her. I mean, even when he comes out of his car and he's going back into the car, he disinfects the car on his own sake. But yet he caught it. So it still remains a mystery. We just have to be praying each day that we are lucky that we don't get exposed. Sorry, I can't hear you.
So you were in ICU for 2 days, which certainly means that you were one of those in a situation that was critical and you could have died. Tell us more about the encounter, starting with how you ended up in the hospital. So
do I start from how I ended up at the hospital or how I got to the ICU?
How you ended up in the hospital in the first place?
Well, so latter parts of May, I remember very well, I was in town. I'd actually gone to East Legon on an errand. And whilst driving, I felt very uncomfortable, that I was running temperature and I felt feverish. So I drove back home. And when I got home, I mentioned to my wife that I wasn't feeling well. So then my little boy came to me and checked my temperature, and my temperature was around 37 point something. So he said, "Oh, Dad, your temperature is high." I went straight into bed. I think initially took a painkiller, went straight into bed to see if the temperature would go down or my feverishness would go. Subsequent to that, I think the temperature kept going up and up. So the following day, I think I called my doctor and I mentioned to her that this is what is happening, but I keep on running temperature and I'm feeling a bit feverish. So she advised that I take some paracetamol, which I did. I think, for some 2 days. The temperature drops and goes up again and so on and so forth. So I think the Monday, this must be a Thursday or a Friday, I think. The Monday after I decided to go to the hospital. In fact, a friend who was a doctor came home to test for malaria. There was no malaria parasite, but then he insisted that I should go to the hospital on Monday. So on a Monday, I went to the hospital. My doctor did malaria test, a typhoid test, also did a test to check whether there was an infection. And there was nothing like that. So we agreed that I should do a COVID test. This is a Monday. So when I got home, I think I called the clinic that I did my initial test, and I was made to understand that they did not have the swabs. So they will call me as soon as they get some. So this is until I think a Thursday or Friday that I went for the test. But meanwhile, my doctor had given me some medication, some painkillers, some antibiotic as well to be taken. So during that entire week, I was consistent on my medication. So I even had the test on the Friday or so. But by the day, I felt weaker, even though I was taking some medication. So yes, I did a test on Friday, but the Monday after, I felt extremely terrible. So a good friend of mine had called a friend who was a doctor to tell the doctor how I was feeling. Apparently, the doctor even mentioned to him that he suspected COVID. He was 100% sure that it was COVID, but the friend didn't tell me. I think he didn't want me to panic or didn't want my wife to panic. So I called my doctor and said I needed to go to the hospital and asked whether the results was in. I said, no, the results is not in, but I have to go to the hospital. The way I'm feeling, I can't be home. So we ended up at 37. By the time I got to 37, I was literally losing my breath. So immediately I was put on oxygen right at the, I don't know whether they call it OPD or so, emergencies department. So yes, I was put on oxygen. Then, of course, because I couldn't walk, because I could barely take about 10 steps. That's how terrible it was. And this is somebody who I walk about 8 kilometers on a daily basis. So not taking 10 steps was scary. So well, they took me for an X-ray. I had an X-ray, and then they noticed that I had a lung infection with pneumonia. So I was quickly admitted. At this time, we were waiting for our COVID results. So, well, I was admitted on the Monday at 37, drips, what have you, blah, blah. Fortunately, on Tuesday morning, I got my results, which had tested positive. So I had to be moved to an isolation center. So the closest one was the AMUAH Stadium. And if you know the AMUAH Stadium, it's an isolation center, and they built some military tents there. So I was taken there in an ambulance. And the very moment you test positive, you become government property. So even though my wife was there with our car, she was not allowed, I was not allowed to sit in the car. And I was put in an ambulance. Ambulance, I'm not sure if we go to Winnipeg, but it took me to AMUAH. Yeah, well, I got there, still on oxygen. I was placed on oxygen somewhere a few hours after I was put on oxygen. I ran out of the oxygen. And in the tent, the nurses are not running regularly. So you need to call on a Motorola walkie-talkie for them to come to your tent and give you oxygen. If I'm not kidding, it must have taken about 4 to 5 hours before I got oxygen. I had to be calling friends to follow up at the hospital and follow up with, all sorts of things. And eventually a nurse came, moved me from the bed on which I was lying to another bed where the oxygen was working. So I was given oxygen again. And then around about 2 a.m., I ran out of oxygen again. So I ran out of oxygen and I had to lie down till morning without oxygen.
Russell, what was going through your mind at the time, knowing that you had run out of oxygen?
A lot. A lot. I think my first scary experience was when I got up of the bed to pass urine, and I got back onto the bed. I thought I wouldn't survive by the morning. It was so scary, Israel. It's I cannot explain. But so when I managed to lie down till about 6 a.m. and the nurse got in, I said to myself, this is a mental fight. I needed to be strong in the mind that I'm not going to go anywhere. So yes, in the morning.
Whilst talking, you get to a point you were saying you were hesitant in talking about the actual experience. But one of the reasons why we're doing this is because there are people out there who actually feel that coronavirus is a hoax. It's not real. So if you may, would actually like to hear some of the details, some of the scary details. Hopefully, people out there will take a cue from it.
Yes. So one of the things, I was not in pain, but I felt extremely weak. I mean, I could barely take 5 to 10 steps. So even to get down and pass urine and get back to my bed was scary. I mean, you get back into your bed and the way you are panting makes you feel you are just going. And the thing is that there's nobody around. I mean, the person next to me was also somebody who was on oxygen, and an elderly woman who I could see she was also struggling, and I couldn't obviously call that person for help. I tried at a point in time to call a line that I think a nurse or a doctor called me on, and nobody would pick it. And this is around 3 a.m. So at that point, it was myself and my God. I just had to lay down flat, and I kept panting. And I noticed that I was just losing my breath gradually. So at a point in time, I was scared to even close my eyes, because I was scared if I closed my eyes, I would not wake up again, That's the thing. So fortunately, in the morning, a nurse came by. I had to go pass urine. And, in the tent, there are no washrooms. So then I had to walk and this is AMUAH. So you needed to use the facility in the stadium. And that should be about more than 100 meters. And with somebody who could not take 10 steps, I needed to do that distance to just go and use the washroom. I think that was where I was able to put myself together, and I was strong enough to decide that, look, come what may, I need to be strong to survive. So yes, with the experience from Tuesday night till the morning, I think that we made phone calls that, look, I need to be moved from AMUAH, because I felt that my situation was critical. And I think that a few friends of mine made the phone calls here and there. And finally, UGMC agreed to fetch me. So I think about 3 o'clock or 4 o'clock on Wednesday, an ambulance came for me, and then straight to UGMC, and then straight to ICU. I must say, the doctors and the nurses are doing extremely well. They are so professional. I mean, and you could see they go all the length to make you safe. When it comes to them, I'm lost for words. It's how to describe the kind of work they are doing. So yes, I was in ICU, and as soon as I got there, I was assured that I'll be well, and I should just relax.
Doc, Russell, did you believe them? Sometimes, they'll tell you, they'll give you all the assurances, but then you're wondering, okay, are they just telling me something?
Yeah, Yeah, Israel, I think yes, because, you know, for what I think I've seen at AMUAH and the kind of reception I got at UGMC, I think instantly it gave me some level of assurance.
Okay.
Okay. This is a situation that you are coming from a point that when you run out of oxygen, it took several hours for somebody to attend to you. Even when they moved you to the next place, you still ran out of oxygen. You didn't have a convenient, even to use the washroom was a problem, or you had to walk. I mean, and then you move to this other facility that they are so receptive. They come to you and they run you through the process, what you'll be taking through. I mean, I think that the assurance was there instantly. And I think that I had no doubt in my mind that I was going to be well. It came across that this is a well set up place for somebody who was in a critical condition than where I was previously. So I think that coming from that angle, yes, I was assured that I'll be well.
All right, but I'm sure you had also heard that you know, people end up in ICU and they don't come out. I mean, they don't survive. So knowing that you're going to end up in ICU and the 2 days that you spent in ICU, tell us about it.
The 2 days, I would say, look, for almost every 30 minutes, the doctors were coming to my bed. Almost every 30 minutes, the doctors were in my bed to check whether my oxygen levels were okay and whether my BP was okay. My sugar levels was checked several times. You know, I think that hours into my being admitted to ICU, I was a bit relaxed. I must say though that prior to leaving AMUAH, I was scared. I wasn't too sure of what the turnout was going to be. But then somehow, with the kind of reception I got at the ICU at UGMC, I had some level of confidence, and the nurses and the doctors kept telling me that I'll be fine. My situation is not that bad. They've seen even worse cases, and I think that it did encourage me. I met somebody who had been in ICU for 13 days in coma. And that person said, look, when he opened his eye, he thought he was in some hospital abroad. I mean, he did not know how he got there. So in my case, at least I could see the ambulance taking me to UGMC. When I got there, when I was put in the wheelchair, I could see people around me. I think I was a bit lucky, I must say so. But people had gone through worse situation, and I think that yes, there are times that when people are there, they don't even think that they may survive. But of course, by the grace of God, we came out, and we are grateful to God for that.
Yeah. And I can understand, thank you, Russell, for sharing your story, but I can understand why you decided that you're going to do your own bit to support the frontline health workers since your recovery. And I'll give you the opportunity to tell us all about that. But I want us to move on to Dr. Kaba Akoriyea. We're having this conversation, Doc, mainly because the workplace has become a hotspot according to the Ghana Health Service. Indeed, I recall how more than 500 people as a fish processing factory caught the virus apparently from one person. I'm sure there have been many such transmissions since. What does the Ghana Health Service understand to be the main reason why the workplace has become such a hotspot?
so very much, Israel, and everybody listening to us. But before I continue, kindly check on the chat. I keep getting messages from a lot of people within the sector that has circulated the advert, and they want to get in, but they're not able to get in. So
Okay,
check.
Doc, that's one control measure. We're trying to limit the number of people who are showing up, because otherwise then we're going to have it crowded, and people disturbing the feed as we're going along. But they can monitor on, there's a link to this on Facebook, or in fact on Facebook and also on YouTube. So they can follow the conversation there. So it's on YouTube.
Okay. All right. Okay. Because they keep putting it that they want to get in with it. Anyway, so thank you so very much. Let me, before I go ahead, I would want to make certain considerations. The first would be to be very grateful to all the health workers and the media so far. The media has been very instrumental in carrying this up, just like what you are doing. And all your colleagues, I wish people would come out to do this to make sure that we create more awareness, because one most important thing in COVID is about awareness creation. I want to make certain consideration. A lot of people talk about workplace, but what we need to break this down. COVID has come to give us that opportunity to break this down a little. When we talk of workplace, people think of factories, people think of the banks, people think of big places. But your security guy, his workplace is your house. Your nanny who helps you, his workplace is your house. That big guy who is driving, his driver's workplace is in his car. And when they close from work, they need to catch a bus. They have to catch the trotro, they catch the commercial vehicles back to their house. And those are the little things sometimes we tend to forget, that we live in a community, we live in a society. So when you find one in a workplace, it's only telling us that there is a community transmission. So if I come to your work site and I test about 100 people and I find out that 5 are positive and then 95 are negative, it tells me that your workplace is not a problem. Or you go to the school, you find out that in the schools, 6 students are positive. But the truth about that is that the cook in the school workplace is in the school. We are only thinking about the children. The security man in the school, the teachers in the school, their workplace is in the school. And so people are actually taking it from the community back into the workplaces. That's the first thing that we want to make clear, that we should always try to break this down and understand it from that perspective. Then we can develop a broad-based, comprehensive strategy that will tackle this at the same time. It has to focus on everything at the same time. You cannot say, I'm going to focus on the factories, then after that, I'll focus on schools, because COVID-19 is everywhere at all the times. So you got to develop strategies that will address COVID-19, focusing all the time in all the places in all the times. You can't address one place and leave the next. You have to address all. And that brings to 3 or 4 fundamental things. One is the governance, where we are humble to let people know what is happening. You educate the people, and then you provide the necessary enabling environment and logistics for people to get the job done. Then 2 comes the most important thing, which is the community engagement and community empowerment, where we try to empower the community and engage them for them to know. But it all boils down to one single important thing, which is the individual. That individual and the household should know exactly, understand, should be educated on what COVID-19 is, because at the end of the day, the individual matters. Is what each of us do, how we understand our community risks. If you go into a funeral, you know that it's a crowded place, you need to take certain measures. So the individual has to now understand that and make sure that we protect ourselves. And that individual has to practice one single important thing, which is solidarity. So for instance, if I have all the hand sanitizers in my car, my driver doesn't have, because he can't use his salary to buy. And then you keep seeing me sanitizing, but he's not. When he leaves the car, I take over the wheel. There I go, I get it. If my house help comes to the house and she doesn't have that possibility to sanitize herself, I'm gone, but she's with my kids. She's the one who goes to the market to come back. Or if she doesn't even understand that when she gets to the market, she needs to do social distancing, or she can't be buying face masks all the time. It's my job to make sure that we help them. And that comes to that issue of the solidarity I always talk of. So when we understand these basics, then we can now look at it and say, look, all workplaces have to adopt certain measures, looking at some things. I always try to break this to make it in a way that people can actually focus on them. One is infrastructure. If your workplace is a big place and you have, let's say, what we call occupational health safety person, then it makes things easier because then there are health staff who can actually get, but it's not all workers or all workplaces that you get that. You can have a place where the people are few. Then you say, okay, my infrastructure cannot accommodate so many people. So what I can do is to look at it and say, okay, some people can come to work this week, some can come next week, or some can work from home depending on your ability to have this internet and work from home. Then you educate them to at the workplace. You make sure that everybody is educated about what it is. There is one thing everybody keep talking about, which is the social distancing. But the truth about it is that it's very, very important to keep 1 meter from someone. But from our culture, from our regular practices, that is one of the most difficult things to do. Imagine you are at your workplace and then you carry a document from one office to the next and you stand at 1 meter, you got to drop it halfway and say you to come halfway and pick it. So it becomes so difficult for us to do. So because of that, we are now saying that wearing of face masks is non-negotiable. When we started it and I started talking about face mask, back in those days, people were like, okay, Dr. Kaba, WHO said this. But today we found our European countries even putting fines. In the US, you have states that are also doing the same thing. So to me, face masks at the workplace is non-negotiable. If you add a shield, good, but not just putting the shield without the mask. The shield should complement the mask. Then you're supposed to make sure that at the workplace, you have all the measures of having the hand sanitizers, putting the Veronica buckets with the water for people to be able to wash their hands, and making sure that personal hygiene is prioritized in all the offices, all, not one, not two, all. Before you get in there, you have those items that people, the logistics that people can actually use to sanitize themselves, and make sure that the cleaners understand what is going on. And then when they open your door, you sanitize it. When people come and they use the table, you clean the table. Those are the things.
All right, we seem to have lost Dr. Kaba's connection there at this point. Dr. Kaba, you may probably want to reconnect and then you can get back to us. But let me bring in Noella at this point. Noella, by way of introduction, I'd want you to share with us what the COVID-19 situation is like in Rwanda. According to your health ministry, Rwanda has just about 1,500 confirmed cases and 5 deaths. And for a population of 13 million, you have conducted 207,000 tests. What is it that your country has done to maintain such low figures?
Yes, thank you for having me as part of this conversation. And one thing that you just mentioned, you know, the settings are different. Different countries and different parts of a country are at different stages of the disease. But by way of introduction, the current situation that you just mentioned, we had our first case on March 14th. So we just crossed the 4-month mark since the first case was reported in Rwanda. And so some of the confirmed cases that we've had are a little over 1,500. We've had more than 800 of those recovering. So they've already exited the treatment centers, and we have active cases around, it's around 700. And so unfortunately, we've had 5 deaths in the country. And the focus, I think, for us has been on testing widely, expanding the testing, right? So on one hand, there was this early action because preparedness for Rwanda started actually in January when we had the first reports that there was a virus spreading in China and that had started to affect different parts of that area. So when we looked at the public health measures, we focused on largely on testing because that's how you know the situation, right? So I guess we can come back to it later and focus on different parts of this, but it's sort of as an overview. That's what we've been able to find.
Noella, when you say you started in January, what exactly did you do in January?
So in January, we were the focus for the surveillance, and we've remained on high alert throughout, right? We don't see it as the fight is not over, right? We've remained on high alert. In January, at points of entries, we're talking about airports and borders, we had screening. And at the time, it was thermal screening. It was multiple levels of screening, but it was symptoms-based screening. So say the international airport here in Kanombe, as you're coming down at arrival, we had temperature screening. And then we also had various sort of primary screening depending on levels of risk. So for example, if you have a plane that's coming from a highly endemic or a country that we know has a community transmission of COVID, and at the time there were several countries that were known, we would let you go through just a few questions to estimate your risks. And if we felt you were at a higher risk, we would then take you to a secondary testing and screening, which led in some areas to the test. And so that was early in January. Actually, that was towards the end of January. But then in early February, and throughout this whole process, we also insisted on public health measures. We started installing hand washing or having hand washing stations across many various settings, and enforcing physical distancing. And I want to draw a nuance here. So we try not to use social distancing, and we use physical distancing because the difference is huge, right? We're saying.
Okay, so tell us about the difference.
The difference, I was hearing about what Dr. Kaba was saying, and earlier what Russell mentioned, right? There's this idea that in our cultures, when you say social distancing, you may not be communicating what we want. What's important is reducing the risk of infection by physically being at a distance versus saying, shut down all your social connections. And this becomes important as you treat the person, because again, you treat the person as a whole, and these social contacts are important, right? So what that means is I may not be able to come and see you, but I can pick up the phone and call you. So we've been intentional about what we use when we communicate with the population.
All right, so the other question I want to ask is, how are you able to conduct so many tests? You've done what, 207,000? Because I mean, we hear of shortages, that it's difficult to come by these tests. And yet a small country like Rwanda, well, small, not necessarily small, but small country like Rwanda has conducted 207,000 tests.
Yes, so, sorry. Can you hear me?
Otherwise, maybe probably let me just add that, how are you able to mobilize resources for the fight?
Okay, so I lost you for a few seconds, but you were asking about the testing and then the mobilization of resources.
Yeah. I mean, how are you able to conduct so many tests? Because the test kits, we're told, are difficult to come by. Everybody's going after the test kits. So how did Rwanda manage to secure your test kits?
Mm-hmm. So as you mentioned, when you speak of testing, there's issues in the supply chain, and there's a large shortage, but there's also issues when it comes to the workforce, to the materials, to the equipment. So when we approached it, we really approached it as a whole. We said, how do we expand our testing? And so in terms of the supply, we have been sort of intentional about securing the supply, and that started quite early on, meaning that we were able to develop partnerships that allowed us to be able to have access to these supplies. So that was the one, that was one of the steps of how we were able to expand the testing. But it's not just about the supplies, right? So once you have them in a country, it's also about making sure it gets to, especially those that need it the most, those that are at high risk. And so we were able to expand our network of labs, not just have one central lab, but really build satellite labs that were able to run the test. And another method, which is an innovative strategy that we did, I think people are starting to hear more about it. It's not a breakthrough, but it's being applied more and more in countries like Rwanda, is called pooled testing. So with the limited supply, you have to be intentional. So it's about combining several samples, which is the pooling side, and then testing them in a single tube, right? So you'll have batches that are negative. So then you've saved on the tests. If you find a positive sample in that batch, you then have to run it individually. But something like that can help you save thousands of tests. So we've increased our daily testing capacity by several folds. Early on, I believe in March, we had an approximate daily capacity of 300. And we've been able to expand. We're now at 3,000, 4,000, and we crossed the 5,000 threshold, I think some point last week. But we're looking to keep increasing because expanding testing is so important. So using these strategies, whether it was securing the supplies early on, whether it's the pooled testing, because then you're able to provide more tests without using that much supply. And then also building a network of labs so it's not just centralized, but really across the country. Things like this have allowed us to really expand our testing.
All right. So thank you very much, Noella. I'll be coming to you, but one thing I should say is that here in Ghana too, we've also deployed the pooling method for testing, and it's also worked quite well. But there are those who say that when you have a lot more, when the positivity rate is low, it's fine, or the pooling method works. But when you have a high positivity rate, then it becomes difficult to use the pooling method. So yeah, probably for now, it may work. The pooling method may work fine for you, but subsequently there could be a challenge if you have a lot more cases that you're having to deal with.
Yeah, I think that's an important distinction. Like I mentioned, a country is not homogeneous, right? You'll have some areas that have a higher level of risk or a higher level of recorded prevalence of the disease. So in that area, you have to be quite mindful of that. And so with the pooling, you can actually do different level of dilution. So you have to adapt as you go. And it's an important distinction that you make.
All right. Would you say that the workplace is a hotspot for COVID-19 in Rwanda?
Yeah, so when you look at hotspots, right, it's about understanding the transmission dynamics. One thing that we found is quite, and not just us, but other countries, is these silent transmissions, especially when there are no measures in place. By silent transmissions, I mean, when you're in the pre-symptomatic phase, so this is before you exhibit any symptoms, or whether you are asymptomatic. So that means you have the disease, but you have not developed the symptoms. So outwardly, it may look as if you are okay, and so you may be spreading it without knowing it. So places like the workplace, as Dr. Kaba was mentioning, is such a large spectrum. It can be the floor, like you could be a trader in the market, right? You could be a farmer in the field. You could be an office worker. You could be a bus driver. So what's important here is to look at the workforce, but within the broader perspective of community. So whatever measures you're applying in the workforce must fit into what you're doing widely in the community. And we've mentioned them. We know what works. We know that wearing face mask works. We know that frequent hand washing works. And we know that physical distancing works, not one at a time, but together is when you're able to reduce these risks. So that's how I would say it. So it's a workplace, but even wider community-based measures are able to to curb the risks.
All right. Noella, I'm sure some of the other panelists would have questions for you. I have some more questions for you, but we will also shortly be hearing from Adebayo AKINLOYE, who is representing Nigeria in this conversation, what he makes of the management of COVID-19 in his country and the advice he has as far as dealing with the pandemic at the workplace is concerned. But let's return to Ghana for now and to Dr. Hazel BERRARD. AMUAH, you're part of this conversation mainly because of your expertise as far as human resource management is concerned, but you're also HR director for an FMCG, and indeed a large one. What is the situation at FunMilk? All right, Doc, I think you should unmute your button.
Great. Can you hear me now?
Yes, we can.
Okay. So thank you for the opportunity, Israel, to be on the show. And indeed, the situation in FunMilk is very calm today. The reason being that just like the story that Noelle was sharing on Rwanda, earlier on when we began to hear about the pandemic being one that was transmitted by travelers coming through and through the various borders, i.e. the airport and the land borders, we began to really kickstart and put in place things around our contingency planning and making sure we had a crisis committee set up immediately to begin to, be more aware of everything COVID related. So what we did as a business was to really begin to identify the original source of information around COVID, for example, World Health Organization, the Ghana Health Service, et cetera, to really have authentic information around everything COVID. Second thing we did was to really learn from the countries where COVID was very prevalent, i.e. China, America, Italy, and so on and so forth, to sort of learn how they were dealing with the crisis, because at the early stage of the pandemic, it was very different to what we have today, where we have a better understanding about how the virus even behaves, So we had to really gather a lot of information around that and ensure that from an education perspective, we educated all our employees and encouraged our employees to also educate their stakeholders or their significant others, being the larger community, their families, where they interact and so on and so forth. At the time that COVID became very clear in Ghana, we didn't have a lockdown system. We didn't have whether it's physical distancing or social distancing. But what we knew was if you wore the face mask and you wash your hands regularly with soap and the running water in a particular way, thorough washing of hands, and also sanitize regularly, you'll be able to protect yourself and others from the pandemic or from the virus. So other things that we did was to really even find out the type of alcohol that was really very potent to be able to clean viruses very well. You'd realize that there are so many sanitizers on the market today. The alcohol content of these are not necessarily the same. Other things we did was fumigating the entire campus or the entire factory, even air fumigation, which I didn't even know about, till this pandemic. We fumigated the whole, office environment, the air, to make sure that, people were safe, because for us, people is our most important priority. All these things came under our crisis management approach, because when you have a pandemic of this sort, you need to quickly kickstart into place and into motion things that protect first your people. So we had constant education. We had medical people coming through to give talks, to give counseling, to sort of also manage the anxiety that comes with, the pandemic. Dr. Kaba mentioned something that was very, very important in terms of commuting to work and where people find themselves outside of the office. And for those who have drivers and have, nannies and housekeepers at home and all of that, there are various angles through which you can actually contract the virus. At the time also, mosques were open, social gatherings were not limited. We had churches opened, we had large funerals, we had large weddings, we had all kinds of social engagement. So the education started with our employees to make sure they were self-protecting and also being advocates and icons for others to protect themselves. So information sharing was very, very critical. We shared information from TV screens, from WhatsApp platforms, from town hall meetings, from newsletters, from emails, from all kinds of information all the time on what COVID was and what COVID was not, and to sort of break the myths around COVID and also bring more truth to what COVID was really about. So it was a very strong intervention we put in place. Now, you mentioned me working for an FMCG. So FMCG, this one is about making food, and food that goes, was consumed at a very high rate. So we had to review again and still step up, which was already high, how we managed our staff who handled our food, for example, just to make sure that there was no stone left unturned. We also put in place all kinds of things like Veronica buckets all over the place, our hygiene centers in all our RDCs, and all our agents were, also educated. So it was really, really very, very critical. In all of this, what was important was the constant decision tree and the constant checklist to make sure that all the items that we highlighted as possible risks and areas of concerns were properly ticked off, and all of that. Also in compliance with not only global standards, but whatever standards the Ministry of Employment and Ministry of Trade and Industry were publishing as guidelines about how to manage the workplace. So these were some of the things that we put in place to make sure that we kept our employees very calm and protected, and also continuously engaged them to be aware of what the risks of having the pandemic were about.
And you believe that these things that you did has been able to help you bring it under control in the organization? Would you say you've brought it under control in your organization?
It is under control. It is under control because we have not recorded, cases that, have, ended up in the very unfortunate situation that Russell found himself in. So if you continuously create a consciousness, it becomes a habit. This pandemic broke out in December in Ghana. First case was in March. With a constant education after 21 days, this practice becomes a lifestyle, a habit. So you actually find people, wearing masks all the time. And there are times that even have the physical distance, or they are really, really like one person in a meeting room and they're wearing a mask because they become so aware that they have to protect themselves. So there was no stone really left unturned in terms of how we managed it. So we really have it under control.
And I'm imagining, how do you manage a situation like, how do you manage something like physical distancing, as Noella would want to put it?
So the measurements she mentioned are really apt in terms of the 1 meter, the 2 meter distancing. We had to reorg seating positions in the offices. We had to even shut down the office and make sure people worked from home. So our IT staff had to set up, for those who didn't have laptops and working with desktops, have their workstations at home. We had to make sure we had connectivity and data given to employees, and also train them about how to work from home, the discipline about working from home, how to manage your time, how to, manage the other pressures like family life, children who were doing online studies, spouses doing online jobs as well, in a way that people were fully present to deliver unexpected outcomes. Also to manage anxiety, because the thing about this pandemic is, even if you are protected, you would always hear about some family friend or somebody who's passed on or who's contracted the virus. And that was also bringing a certain level of anxiety. So we had to manage, that stress that came with it. Also, we had to manage how line managers were, given workload and all of that. So these were some of the distancing opportunities, even in the canteen and the factories, how people were seated on the factory lines. We had to slow down the lines and create spacing to ensure that as the belts were running, they were running at a pace that didn't require people to break the protocols around the distance that was required for them to be close to each other. So these were some of the initiatives that we put in place to ensure that we indeed put this under control.
Now, how do you manage a situation where you have a case and some staff have to go into self-quarantine, which means that they will not be available as a human resource? How do you deal with that?
Okay, so let me just say that in terms of self-quarantining, it is not peculiar to COVID, right? Self-quarantining is actually relative to every disease that's communicable. So if you have somebody with a very bad flu, or somebody with a very terrible cough, or any communicable disease or any airborne disease, you have to self-quarantine. So we have demarcated places where if anybody was showing any symptoms of any communicable disease, they would actually be isolated there until they're evacuated off-site. But given the COVID situation, we've had to actually make a conscious effort to educate everyone through communication that if anybody was showing any symptoms of the COVID virus, that is the place where you'd have to be self-quarantined to temporarily while we get the doctors on site. We have a health clinic on site where the doctors would quickly, come and support and make sure you're evacuated and giving the right support to the places that Russell mentioned in his discourse in terms of the isolation and all of that. So that's what we've put in place in terms of self-quarantining. Plus the education around, if you're coming to work, for example, and you begin to feel sick, don't come at all, stay at home. Or if you come to work and you feel sick, you self-quarantine and you go straight to the clinic, to have, yourself checked out and given the necessary attention. So this is what we've done around self-quarantining, and the education there is very strong. And it doesn't come with any stigma. If anybody is not feeling well, I mean, they're able to feel free to, report and have the necessary attention given them.
Now, from where you sit, you're also a HR consultant. Are there practices that some companies are engaged in that you think are undermining efforts to curb the spread and probably fueling the spread of it?
The practices that undermine the effort of the spread of corona is when you focus on the business more than the people. Because you put your lenses on the business and then you don't educate, you don't spend time to put your crisis management in place, your business contingency plans, your physical social distancing, all the education, wearing masks and all that, and even invest in, upping the sanitization efforts. You put your business at risk because it is people who drive the business. If your people are unwell, where lies your business? So any business that fails to prioritize people in this pandemic and prioritizes their profits or their targets or their expansion capacity or their innovation is actually putting their own business at risk. And eventually, they would actually have a decline in terms of business performance.
All right. Now, Dr. Hazel, I know you've asked that you'd want to be excused, but if you can stay on with us, please do. I'd want to go at this point to Adebayo from Nigeria. Now, Adebayo, you've heard what all the other speakers have had to say about this. You've written a book on COVID-19 and the talent management agenda in a post-COVID-19 world. You're also an HR practitioner as well. Is there anything that you've heard any of the participants say that you think that it's something that you could take or you have added to your knowledge?
Yeah, thank you very much, Israel, and for all the participants. I'm very grateful to be part of this discussion. And I think it's a great work you are doing. I've also learned a lot in terms of what is happening with this COVID-19. And I'm going to look at this discussion also from three main perspectives, and it's about the psychological impact of this COVID-19, and also looking at the emotional impact. Then I picked something based on what Rosal said, the mental impact. So when we look at it from two main areas, people who have contracted COVID and have recovered, and people who have not contracted COVID, but they are expected to work with people who have recovered from this pandemic. How do we manage the psychological impact, the emotional impact, and also the mental impact? As at last week, Friday, based on the data that was released by the Center for Disease Control in Nigeria, the total confirmed cases now was about 35,454. The total discharged was about 14,633. Then the number of deaths as at last Friday was 772. So, and also since the pandemic started, sometime in March, we've moved from lockdown to gradual easing of the lockdown. Also now, some businesses have opened, some airports are operational, some offices now are opening with some social distancing measures. Now they're talking about opening schools. So the challenge now is this, where I want to look at it from the context of work and the work environment. And I was glad with what Dr. Kaba said, looking at the context of workplace. The definition of workplace has changed. Before we started COVID, we're looking at workplace from the context of the four walls of the offices. But now a lot of people have realized that with this COVID, there's a lot of reconsideration in terms of work, the workforce, and the workplace. So now as we bring people back to wherever, maybe to the offices and all of that, how do we manage the emotional impact? Because if you look at it, some people have been working from home for months, let's say since March in most part of the countries or in most part of the world. The issue of prolonged, isolation. People have been isolated for so long. People have been struggling with mental illnesses. You understand? And people who have had domestic issues, domestic abuses. So now we want to reintegrate everyone back to the work environment. And just like Dr. Kaba said, the context of the workplace has changed. So the question is, how do we reintegrate people who have not had COVID-19 experience with people who have had COVID-19 experience and have recovered? How do we build that confidence? Just like it was interesting when Rosa was sharing a whole lot of his experience, the question is, if I work in the same office with Rosa and I was asked to work with him, do I have that trust to be able to relate with him? Even though he has recovered, would I still have that confidence to go and interact with him and believe that I will not have COVID? So for me, you know, the discussion around bringing back that emotional stability, bringing back that confidence within the context of work is a lot of work at this time. While we're battling with the issue of COVID-19 and with the cases that are coming up, also, how do we manage people who have not contracted COVID yet and are expected to work with people who have either contracted and recovered, or they are aware that they've contracted it and their colleagues? So the question is, as we all try to get back into the work context, which I believe it will become normal someday, how do we take it from there and begin to drive individuals to be able to deliver results while still having consideration for lack of trust and being able to relate effectively with everyone? So those are some of the things that I believe we can begin to look at now, because the doctors are doing their best in the hospitals, but in terms of managing the psychological and emotional impact in the workplace, who are we going to leave these responsibilities with?
Ade, I'd want to bring in Dr. Hazel here in at this point. Dr. Hazel, have you thought of what Ade is saying, that some staff would have to come back and they wouldn't feel too comfortable joining?
Yes. Yes, we've thought about, if we have, you know, such a situation in our workplace, how do we handle that? Again, I mentioned the issue around contingency planning and, you know, crisis management. So you actually project and look at the what if scenarios. What if we had employees who had COVID and were, you know, coming out of treatment and having to come back to the office? How we manage them, you know, in terms of relationship. As a company, we take respect very strongly. And so any form of stigmatization or any form of, you know, discrimination is tantamount to consequence management, i.e. summary dismissal. So if we had any employee who was faced with such a situation, the consequence would be there. Secondly, as we begin to evolve and as our relationship with COVID has changed and are becoming more aware and how to manage it, if it gets to the point where we begin to reopen our offices for those who are in the back office to go back to the office, the engagement and the counseling and the psychological, you know, discussions will be very, very, you know, paramount, because you need to make sure that people are coming back and feeling safe and also still adhering to all the standard practices of wearing the mask, sanitizing, keeping distance and all of that, because they'll be commuting from all kinds of different types of transportation to work. So these are things that if we begin to come back to the office fully, we would have to implement. So we've had that plan in place as well, and we would implement that the moment we open up our offices for people to stop working from home and coming back to work. That being said, though, if you were on some of the shows that we had in the past months over COVID-19, you'd realize that from a statistics point of view, from survey information, employees, actually, some of them are actually working better from home than being physically in the office. So businesses want to consider whether they would want to have employees continuing to work from home or coming physically into the office. So these are choices that businesses can make when it comes to responding to the total ease of the lockdown and the total release of the, you know, restrictions. Yeah.
All right, so at this point, let me bring in my wife, Louisa. She is also an HR person. As I indicated earlier, she's working with one of the largest banks here. So Louisa, you've heard what we've had some of the other panelists say, and you've been working from home for a while now. How prepared are you to go back, or how do you intend to sensitize the people when you have to go back?
Well, mine is actually a question. I tend to agree with a lot of the things Dr. Hazel has said, and a lot of the things Ade has also said. I'd like to find out if these plans are going to be carried in a policy, or it's a plan and we just hope to reorient the staff to understand. Because I feel that if these things are carried in policy, then everybody can't help but be compelled to come along with an integration plan when staff who unfortunately may have suffered COVID are having to come back. But if it's not in policy, I wonder how we're going to implement it. Is there anything like that? Dr.
This is like, thanks for that. Thanks for that. Yes, you're absolutely right. Everything has to be policy driven, because here we are in a crisis, right, where everything seems to be all over the place. If you don't manage this kind of situation from a crisis perspective, from a policy perspective, post-COVID, when you have audits, you're going to have lots of question marks and gaps. Then the question is, but how come Mrs. Lai has been working from home for the past 2 years? What was the policy to back or to warrant or to make sure that she worked from home? And how come Hazel, who is working the manufacturing site, is always going to the office? Are you discriminating amongst different parts of your workforce? So policy is one absolutely important part of making sure we have people, adhering to certain standards and certain protocols. And secondly, for post-incident audits, then you have something to cover the situation, to say that even during the pandemic, this was the intervention that we put in place, backed by this policy that we educated people on, and everybody signed on to it. So these are some of the things that, not necessarily in my place of work, but I would advise that companies do. And also the other flip side is, if you have employees who are not comfortable to go back to work because of the risks and the anxiety, we cannot rule those ones out. We have to pay attention to them and see how we can, find a way of still getting work done in a way that makes people safe and comfortable, but also delivering on expected targets. So those would be my recommendations in terms of putting policy in place around coming back to the office after the lockdown restrictions have been totally, lifted.
All right, Russell, you're a business owner yourself, and at some point, I don't know if you said the business had to be closed for a while. I don't know if you're back doing business, and how are you coping? You're the boss. Would you get a sense that people are shying away from you? They're stigmatizing you, and how do you intend to handle some of these incidents?
Okay, so first of all, I think that having experienced any form of stigmatization, I think people have been receptive enough. And indeed, my very nature is such that if you even want to stigmatize it, I leave it up to you. I am very confident and happy. So it is, if you want to judge me because I have contracted COVID, and therefore it affects my ability to deliver, then it's entirely up to yours. But in terms of work, first of all, work industry has been affected badly because of COVID. And therefore, I also thought that it was not the best to encourage workers to be coming to the office. And so since March, we've not been at the office. But what we do is that if there's work to be done, we work remotely from home, and it's proven effective. I am the last person to want to put any of my team members into this situation. And the thing, like I said, is that you do not know where you can contract it. It could be in the trotro that they will sit, or in the Uber, or whatever. So staying at home, it's the safest I can think of for now, and I will continue to do that.
But you need to run a business as well. Yes,
the business can run, and we can run from home. A lot of businesses are running home now. It hasn't affected their ability to deliver. So I think that that can be done. The thing is that business rather is on the downside. So we rather hope that business will pick up so that the business doesn't struggle. Even though people are home, you are compelled to remunerate them on a monthly basis. There are certain fixed costs that you cannot run away from it. You have to pay your office rents and so on and so forth. So it's essential that business picks up so that we can sustain ourselves in industry. That's for me the troubling part of this whole thing. But I don't think that working at home and allowing the team members to work at home would greatly affect our productivity.
All right. Now let me go to.
I keep on saying that COVID is so real. I mean, I have seen somebody drive with a spouse to the hospital, and within 30 minutes, the husband passed as a result of COVID. I've seen somebody who was in a critical condition who at a point in time, and this person probably is a very wealthy person, and at the point in time, money even couldn't buy his or her safety. So it is something that we do not have to joke. We don't have to joke with it at all. Okay, it's not something I wish for my worst enemy. So it's important that the protocols are kept. It is important that we do the right things and make sure that we keep each another safe.
All right, thank you, Ransom. So I'm bringing in Dr. Kaba again. Dr. Kaba, we lost you at some point, but I'm glad that you're back on. Now, I would want to ask you, what has been the level of compliance when it comes to observing the COVID-19 safety protocols at workplaces? Do we still have Dr. Kaba? Can you hear us?
Oh, yeah. Okay. Yeah.
All right.
Sorry, I had to unmute myself and I just forgot. So as I was saying, was that we've observed certain trend of activities happening. And the most important thing in this always come back to the same point, the community transmission. And the workplace is also right in the community. So whatever happens within the communities, whatever is being accepted within the community is what actually leads to other people actually complying or not. What we've observed is people try to use the face mask, but at the same time, it's now like a chin mask. It doesn't really cover the mouth, it doesn't really cover the nose. And we do believe that with a lot of enforcement, because as I said, the use of face masks is non-negotiable. With a lot of enforcement, we should be able to encourage, especially the young ones, as being the major issue, whereby we've noticed that because they believe that the one way or the other, when they contract the disease, they might not be so affected. They are not the compliance is a little bit low. But in workplaces, people try to do it. But the question is, if you do that whilst you are at work and you leave the doors of your office and then you take off your mask, we go back to zero. There is also another thing we need to really talk about, which has to do with the stigmatization. In the case of Mr. Russell, he is the boss. So definitely people, whether they like it or not, they have to interact with him. And that also brings to the point that if we get faces like him, if we get ambassadors like him, if we get influential people talking about COVID-19 and how real it is and how they have contracted it and how they've survived, then this whole stigma, when it is reduced in the community, you can be 100% sure that at the workplace too, it will be reduced, because then the anti-stigma too becomes a new normal where people will not be stigmatized. So these are things that I would want us to really talk about and really keep doing, right from, as I say, the government will do its best, but then it's also the community and that individual to also take this responsibility and keep educating and educating. Workside, one important thing is to keep educating and educating the people about the COVID, and also to make sure that when somebody is actually not feeling well, you should realize that it's better to let that person stay home for the number of days required. It could be the 14 days or not, than bringing that person, and then at the end of the day, you have the whole factory shut down, the whole industry shut down, because then you have 10 workers, 20 workers, or all the workers infected. So business owners will have to look at this and look at the cost involved in allowing one person on that leave as to wanting to delay and say because of the work. And I really like what she said about human beings first and business second. Then we can all thrive. But Israel, I will keep repeating, it's about the whole real deal here is community transmission. And the whole real deal is to be able to develop a broad-based strategy plan that will suppress everything at the same time. It will address everything at the same time so that you can suppress the transmission. You cannot select and say, I'm going to do this at the workplace, but I will not do that at the marketplace. I will not do this, or after the workplace, I'll jump to schools. After that, then I'll come to my home. It got to be applied at all the places at the same time. That is how the only way we can actually suppress this virus and live with it.
Dr. Kaba, I recall a comment someone posted on one of my COVID-19 tweets. He has, could the extent of interactions or periods of contact be a factor? So where you have less sustained interactions at the market, for instance, resulting in smaller viral load being shared with little risk of infection. The opposite at our offices mean greater viral load being shared with a higher risk of infection. Is there any research pointing to this?
Yeah, there are so many researches in this, and what we don't know, what the person is virtually talking about is the route of transmission, whether it's oral, it's airborne, whether they found the virus in fecal, urine, or in the blood. Now, the reality is that in the world right now, when you talk about the route of transmission, it's a living review. That means that it's being reviewed every day. Today you hear they're talking of airborne, tomorrow they're just talking of the droplets, the next day they're talking of this. So, but the most important thing that we need to understand is that we need to take all the measures, irrespective of the route, to make sure that we protect ourselves. But yes, I'll be more categorical to that into as well, to that question as well, and that is this. If you stay with a person for a longer period of time, of course, then you stand a chance of contracting it. The intensity of the interaction matters. The intensity of the contact matters, and the length of the contact also matters. So these are all things that we need to be considering. Of course, in the workplace, if you're in the air-conditioned room with, let's say, a small room, 4 people in air conditioning, and you don't open the windows, we are talking of ventilation. And then the person is briefing you, are not using face masks, you are not using all this, the things we've spoken of, the protocols we've spoken of. Of course, then what happens is that the virus will just be circulating within the same condition. And I will give you an example. When we had our first cases, and we realized that the people who came to the East Hospital at the beginning were recovering very fast than those who we kept at home, and they were all the time in their air-conditioned rooms, and they weren't coming out. They spend more time to have their second double negatives, because we thought that they were just circulating the virus among themselves. But when you are in that open, when you are in that place where you can actually be with less people, but at the same time you have good ventilation, then we believe that your chances of recovery is faster, and the transmission to other people too is very low. So yes, those things are all considered. But let me categorically say this again. In the world for now, we've spoken of droplets transmission. People are talking of airborne. We are not 100% sure of all the routes of transmission. And the only assured way you can protect yourself is to observe all the things we are talking of, whether it's social or physical distance. The use of face masks is non-negotiable. I'll keep saying it, because then, especially at the workplace, where I will take a file and go to the next person to have a discussion. We might have distanced our chairs. You might be 1 meter away from me in chair, but when it comes to that, but I have to come to you to discuss something. And if I'm not in my face mask, then we're going back to the same thing that we're talking of, zero. We're transmitting to each other. So that is very important to me.
All right. So Dr. Kaba, I'll be coming to you. Again, you're going to be staying with us, but one person who's going to be leaving us shortly is Dr. Hazel AMUAH. She had indicated that she'll be leaving around 12 o'clock, but she spent some more time with us. So thank you very much, Dr. Hazel. Before you go, though, this is a question I'm going to be putting to everybody else. So I'm going to ask you that before you leave. What are some of the weirdest untruths or misconceptions you've heard about COVID-19, apart from the fact that it's not real? Because at some point, as some people want to put it, they haven't seen anybody with the disease, and so yeah, it's not real.
Well, that's a good one. The weirdest one I've heard was actually, I saw it on CNN, and there were a number of people who said that God gave this nose for us to be able to breathe in and out through the nose, and same as the mouth. And if you have to cover it, it means you are an agent of the devil who is helping to bring the world to a very uncomfortable place. And at that point, I was so much in stitches, I fell off my chair, because the thing that people will think that there is no such pandemic and therefore wearing masks is the satanic agenda. That was totally ridiculous. So I found that very interesting. That's one untruth that, you know, it's both funny and actually ridiculous. Yeah.
All right. Thank you very much, Dr. Hazel. So we can excuse you now so you can go on to your other business. That would leave only Ade as the lone standing HR guru with us. So Ade, I would want to put the same question to you. What's one of the weirdest untruths you've heard?
Yeah, thank you very much, Israel. I think one of the things that, you know, though very funny, is that people have been saying at least it's something that will kill an individual. This issue of COVID, you know, people have suffered, you know, a lot of other diseases even before now. And people were thinking that, you know, this was just like the ordinary thing that people have been going through. So it's like you said before, maybe it's a scam for some people to actually exploit the wealth of the nations and to do all sorts of stuff, or for some people to actually sell their medication and whatever it is. But you're hearing from, you know, Rosa and what he has shared, you will know that this is real. But, you know, just like you said as well, people are waiting for, okay, can you show me somebody within my vicinity who has actually contracted this thing? Then I will be able to say that, okay, maybe this is it. Some people are even saying it's just malaria that has been aggravated. So when you look at it, how do you draw the balance? People will say, okay, this is malaria. Most of the things that have, even some people that have received treatment, they say, you know what, all of the treatments that I've received were just similar to what someone who has contracted malaria will have been given. So what is the difference? So I think the awareness is very important, but just like we're talking about the reintegration plan and all of those things, I think the policy awareness, the communication is very key. If we could get people who come out and share some of their experiences and all of that, and we begin to communicate, okay, this is what you need to do. This is how you need to go ahead with what you need to do. And again, we need to let people know that you have to live your life at least as if you have bills to pay. Rosa was saying there are some costs that entrepreneurs must carry. Those costs must continue to be there. So how do you continue to live your life such that the fear factor does not even take over the whole issue of COVID-19? So for me, I think those are key things that we also need to begin to talk about. And maybe later, before we close, I'll also look at the issue of the shift in priority, because this COVID-19 has also helped some people to rediscover certain things about themselves. A lot of employees are not even willing to do 8 to 5 jobs again. So how do we look at that? I think I will leave it at that. Before I will be able to share 1 or 2 things around that.
All right. But before I let you, rest, you've written this book about COVID. I don't think you decided to write a book just because COVID happened. Tell us a bit more about this book of yours.
Okay, thank you very much, Israel. You see, because of my experience in human resources and working across different countries in Africa, you know, at some point, I think sometime late last year, I decided to say, you know what, let me put my experience and my thoughts together in a book, particularly relating to talent management, you know, looking at the entire value chain within the talent management, portfolio, how people recruit, how people retain, how people manage their human capital elements within the organization. And again, as I was, writing the content of the book, sometime in March, I was trying to put the finishing touches to the concluding chapter. And that was when the COVID now became a major issue. And I realized that most of the things that I was trying to share, because the essence was, how do you manage the risk element relating to the human capital within the work environment? Most entrepreneurs, most businesses, they focus largely on the financials. They do financial audits. They do all sorts of audits. But have you taken time to do a human capital audit, looking at how you mitigate risks proactively? And you realize that even when COVID started, even in my environment here, you realize that it was even difficult to get laptops to buy because everybody started working from home. So there was scarcity. So it triggered a lot of risk, and people still needed to do certain things. So I said, okay, let me put my thoughts together. Then COVID came. So I had to look at, how do I realign the topic of the book or the title of the book to be able to fit in within the context. And I'm very glad that some of the things that, that came on board and I included in the book were also some of the things that we're witnessing now. One of them is the context of the concept of working from home, which has been a major concern for some organizations. And you realize that with COVID, all of a sudden, everybody had to realign. So for me, ability to put the experience and to share with business leaders, to professionals, on how to be able to tackle some of these risks that we should expect in the context of work was one of the driving factors. And if you look at it, interestingly, this is quite an interesting scenario. Before COVID, like I said, we're looking at the context of work differently, but now every employee's home has now potentially become a workplace. So everybody who is being hired in an organization, their homes have been taken as a potential workplace. So the concern now is that, okay, what if I don't have a conducive work environment in my home? How do I work? If I'm sharing apartments, you understand? If I have, kids around me that I will not be able to concentrate, how do I manage this? So those are the things that have triggered my thoughts and been able to put this book together, at least to help business leaders and professionals to be able to navigate some of the things we are experiencing now.
All right, thank you. Let me go to Noella in Rwanda. Noella, I want to know, what has been the level of compliance with COVID-19 protocols in Rwanda?
Yeah, thank you. I think it's been a very interesting conversation, hearing the various experiences from Ghana, from Nigeria, from different settings. I'm happy to report that in Rwanda we've had high compliance levels, and as I mentioned, our preparedness and contingency plan started early on in January. So we were building trust, not only through communicating just different measures that were happening, and as we were putting the policies and guidelines in place, making sure that even though some of them were strict, and that's what the disease was calling for, something that's strict and immediate, we were able to gradually lift off or adapt these measures. And so the compliance was high also because we've based it on science and on evidence. And here there is a comment that I've heard before about misinformation. There's actually an even riskier term, which is disinformation, where somebody intentionally spreads the wrong kind of information. So if, say, the general message is wear a mask, we've had some, not just in Rwanda, but outside, having misinformation around the true efficacy. But the good thing is we've been really vocal when it comes to awareness, really vocal when it comes to risk management and community engagement. So we found that those are key, right? And here I have to draw sort of a comment on, you have to focus on various settings differently. So the messaging you have can be quite general, but it's good to really look at settings that have high transmissions. So for example, you may have, in Rwanda, we have 30 districts. And among them, in the past weeks, we had 2 in particular, because they're border districts, that were having spikes in numbers. So in the rest of the country, you may have sporadic cases here and there, but in those districts, then the messaging and the compliance measures are particular to that setting. And I think it's important to be able to have that, right? So I approach each setting differently, in addition to general messages. But there are other measures that help. For example, in Rwanda, if you're not wearing a mask, you actually get fined, because the message has been clear from early on. You have to wear face covering. It's universal, it's uniform, it's everywhere you are in the country. So yeah.
So how much are you supposed to pay in fine, for instance?
I believe the current level we have, I think it's, I would convert from the local currency, $25 is the current fine. But I think what's important here is, although the amount is supposed to carry the weight of the measure, what's important is that it's followed. So we've had we have different people enforce it, from local authorities to line ministries to community leaders to social influencers. It's been quite a whole of government and whole of society approach that's been helpful. Although those measures are in place, what's happening is that rather than have people think of, oh, if I don't do this, the police is going to fine me. It's more of, oh, so-and-so was just on the radio explaining to us the importance of wearing masks and of physical distancing and hand washing. So it's a little bit of both measures that are strict, but also being very intentional about awareness and education community-wide.
So what do you do, or how do you deal with people who will be wearing the mask but will put it under their chin?
That's we've seen some of that, like in any country, and what's interesting here is the language that we use in our country is it's mouth and nose covering. So that's we've observed that whenever, especially early on, it wasn't applied as well. So whenever you have that, the messaging has insisted on wearing a mask properly. And so we've had an adjustment in our communication strategy to say, wear a mask, it's good. Wearing it well is what's important. So the fine can still be applied if you're wearing it on your chin or on your forehead, wherever you wear it. If you're not covering your mouth and nose, because we know those happen, these measures actually still impact you.
And what do you do with somebody who's unable to pay? Not everybody will be able to afford the fine of $25. What do you do with such persons?
So I think it's an important question that you ask, and something that I had drawn upon before is people that are not following these measures can still be. So for example, another measure that we've had is curfew. So we are supposed to be at home by 9 p.m. and part of it was just reducing that window of potential infection. Gradually, this curfew has been extended and extended. For now, it's until 9 p.m. So if, for example, you are still in the street past 9 p.m., right? You are taken to a different place, like a stadium or a different place where you are requested to stay for several hours. And so in a way, it's not just the financial measures, but it's whatever measure is taken, whether it's with the general public. What's important is to carry the weight of why that measure is in place. So if you're not able to pay the $25, there are still other measures to enforce, whether it's the curfew, whether it's the wearing of mask, but it's not having prohibitive fines that will change behavior in the long term. You have to have it along with a very intentional communication and risk communication in particular, and community engagement.
Right.
At
I mean,
least,
it appears there's so much that we can learn from Rwanda. So I'd like to keep you on and ask you a few more questions. Now, how much research has been done in Rwanda on COVID-19? And can you share some of the interesting findings with the rest of the continent?
yeah. Well, we've done research. As I mentioned, evidence and science has been at the core of our national response. So we've had several publications, whether it's about whether it's a publication, whether it's knowledge exchange sessions, whether it's sessions like this one, where we get to share what we're doing as a national response, whether it's in terms of governance, or the type of innovation we've had, whether you may have read about the use of drones and the use of robots, whether it's just how to do a contact tracing and various, or the pool testing. We have had a team of researchers just published in Nature, which is a high impact journal, about how we've been able to adopt the pooled testing, and these efforts are done across. So one example is we have, not just in the publication, but we have a science and advisory group, which is a high profile group of researchers and clinicians that bring in fact-based scientific guidance. And this guidance is actually taken into account when we're developing the policy. So at the Rwanda Biomedical Center, we get to interact with people, and we get to see what other countries are doing, what we can learn, and whatever we're learning from our end, in the lab, in the contact tracing, and in just enforcing these different measures in the governance, we're sharing and sharing widely.
I ask this question because at the start of the pandemic, most of the information that was coming or filtering through to Africa had to be imported. So the Chinese would say, this is the way the virus is spread, and so we adopt that. Mm-hmm. Initially, there were those who were saying that, looking at the way Africa is, the weather is hot, and so we don't have to worry about the pandemic. That's the focus of my question, or the motive behind my questioning. Has Rwanda done something Africa specific or Rwanda specific to ensure that whatever data and science is available to them is unique and will actually work for Rwanda?
Yeah, I think you're drawing quite an important distinction about when we talk about the evidence that's out there, making sure that it's setting and context specific. What we did early on was adapt what, seeing what other countries that were going through tough times, what they were doing, and adapting that to our context. For example, you'll see that a website like the Rwanda Biomedical Center, the Ministry of Health of Rwanda, has these guidelines widely available. They're published. And so we're now at second, third, or fourth versions of these guidelines, because we're learning and iterating and changing and sharing it on various platforms. So you're definitely mentioning something that's very important, which is, can we exchange information among countries, not only on our continent, in our region, but even within Rwanda, right? So iterating, learning, and adapting this. One example that I would give is in terms of isolation and quarantine. Early on, we were isolating or putting people in quarantine for 14 days. And it became clear that we could shorten that measure, but test people twice. So first, when you come into quarantine and say, okay, maybe you're a contact of an infected person. So as you come into quarantine, let's see if you have levels of virus. And then 6-7 days later, we can then test you again. So we realized that we could adapt it from having people stay 14 days to 7 days, but testing them, first when they come in and then before they leave. They leave the quarantine site. So things like this are things that we've tried to share with other countries and published in our guidelines.
All right, is Rwanda developing its own COVID-19 vaccine?
That's, So as you know, developing a vaccine, we've had like, we've heard of hundreds and hundreds of candidates to the vaccine. Rwanda has been following these efforts. We're not yet, I would say we're not yet ready, just like many countries on our continent, but these efforts are resource intensive. And I think COVID-19 has shown us, or has shown us, that we really need to invest in our research and development, especially when it comes to vaccine development. So for now, we're following closely and establishing partnerships and collaboration for when the vaccine candidates go into production. But what we hope to do is actually move closer to developing them ourselves.
Right, I'd like to bring in Dr. Kaba here. Dr. Kaba, you've heard from Noella. Is there anything you'd want to, any takeaways or any lessons that you've picked up, or anything that you'd want to share with us?
Realistically talking, I think Rwanda, first of all, they are doing very well. I've been on webinar with them on Africa CDC. I've even seen how they look at their border towns and the people crossing the borders, and they dedicate policemen to actually work with the borders, work with the drivers from the borders all the way into the cities, and make sure that they follow them right back to where they came from. So, and that has been very helpful, because it's something that they are very good in enforcing the rules. That I think that is one of the big difference that we've observed. But coming to the rest of the thing, like pool testing, actually Ghana was one of the first to start with the pool testing, and we have also decentralized our testing. And the only challenge is that is when if you look, Rwanda is about, Noella, I stand to be corrected, about 12 point something million citizens.
30
and we
million
about,
thereabout.
Yeah, 30 million, and we are about 30 million plus. So definitely you also have to look at the population and look at it and say, okay, if they do 1 million tests, they would have covered over 90% of their people. If we do 1 million, we are just about 10% of our people. So it means we still have to do more efforts. You get what I mean? To get there. However, most of the
talking about testing, Dr. Kaba, it's impressive, isn't it, that they've had what, 207,000 tests. We've done about 336 or 340 thereabout.
You know, it's impressive. As I said, most of the things they are doing, they are able to enforce the rules, and they are able to do a lot. And we are also doing our best. And most of the things we are doing, we are almost all at the same level. And if you look at the way the transmission is, if you get to a place where the positivity rate is very high, then the pool testing is no more working. Then you end up using more resources than you anticipate. But if you go down to places where we don't have positivity rate very high, then the pool testing is applied. So we've also come out with certain strategies. One of the beautiful things we have done, for instance, is designating special hospitals just for COVID. So when you come to look at the treatment of COVID patients with business continuity plan and with people having trust in the health facilities, I think we are doing very well, because then people know that if you go to Rich Hospital, you're not going to pick up a COVID disease and go back home, because they know that COVID patients are in they are in UGMC. So this also brings a lot of trust to the people, and is some of the things. If you look at some of the policies we put in place, like health workers incentives, the 50% plus the tax waiver, look at electricity bills, water bills, these were all government initiatives to make sure that people receive the messages well. But one of the areas that we will need to double up has to do with the stigma, because it's one of the areas that if we are able to get ambassadors and people like Russell that are really respectful coming up and agreeing to actually participate, there are things that would help to actually combat this, and then look at it as a community issue. Once the community accepts it, workplace will accept it, because we are all part of the community. And once they see faces to the disease, you know, you ask a very important question. What I have had a chance to travel down the country, up and down, I mean, the entire country, the length and breadth, for about 2 or 3 times since this COVID started. And everywhere you go, you hear something totally different. So no, from the far distance, so it's Accra disease. Or because they don't, because that's what they believe. They say, for here, we don't have anything like that. It's Accra disease. Some people say, if you believe in God, it won't touch you. So people have different concepts about it. And someone say, traditional medicine. Here, if you take this, there is this guy in the village, if he gives you this concoction, or this one, there is no problem. People kind of look at it from different perspectives. And it's all because of the kind of information that they receive. And it's for us to double our efforts to make sure that there is community engagement and community empowerment for them to actually, for everybody to understand that, look, COVID is real, and it bears to the individual level for us to do the education in our workplaces, in our houses, to make sure that people know that COVID is real. And it's for us to put faces to COVID so that people understand that, look, this person had it, I know him, and the person has testified, like Russell just did, that then people will start to trust. Well, in this office, I can bet you 100% that people believe in COVID because their boss had COVID, and their boss has come out to say that, look, I have had COVID, this is how I felt. I don't want you to have it. And people will change their attitude. And then I think what our Nigerian colleague also said is very important. We've been working on this, which is extremely important to us. That is the psychological component of the COVID. So you see, because of that, in our treatment centers, everywhere we have clinical psychologists. Our schools will deploy clinical psychologists. And we try to look at it from that perspective where people will be psychologically stable to be able to continue with their work and with their schooling, with their everything. So I do believe that there is a lot that we don't know about the disease, and there is a lot we need to learn. On this note, let me say this, one observation from our clinical perspective is that lately we've seen a lot of elderly people who have taken very good care of themselves since COVID started by keeping at home, not going out, and then they come out, and then we see that when we do an X-ray or CT scan of the chest, it's suggestive of COVID. They might not have the test positive, but they always have this as suggestive. And what we've noticed is that it's about the youth. They would have been very compliant with everything. Their children will go out there, or their family members will go out there, they bring the disease back. And when they get it from, then they actually manifest it. So I'll take the opportunity to call on everyone that, look, if you don't even want to care for yourself, the best gift you can give to your own family is to observe the protocols, because you'll be saving your father who has done everything to be at home. And when you don't do observe it and you bring it home and he contracts it and he dies, that's the end of your school, because he's the one paying for your school fees, or that's the end of your auntie who you love so much. So the best gift is to comply with all the protocols.
So Russell, yeah, so very soon it's going to get to a point where really, in fact, we actually are in a situation where we'd have to live with COVID. And at some point, you'd have to get back into the office. How do you envisage the situation when you're back in the office?
Well, Israel, we really hope that things would get to normal at some point in time for us to come together as one family in our offices. I mean, I think it's the wish of every employee, and it is a wish of every employer. Like I said, for those who are employing people, it has greatly affected us because there's no revenue stream, and yet we have commitments that we have to meet. The point is that if you decide to lay off your team, what if things come to normal? Do you have to go through the process of recruiting them again, and so on and so forth? There are too many issues in respect of that. So we can only hope and pray that things get better, and then we enjoy the normal life that we are used to.
And again, Russell, I know that you've been doing something since your recovery for the frontline health workers. I want you to share with us the motivation for wanting to do this. So,
yes, Israel. So, truth is, the enormity of issues in managing this pandemic is so great. And my view is that no single government with the best of intentions can handle it alone. One of the things that I asked myself, based on the things that I was exposed to at the hospital, I said I could have just lost my life. I mean, I could have gone. And for whatever I had would have meant nothing at that point in time. Like I said, there was somebody at a point in time who was willing to pay doctors and nurses to see if they could save their life. That person did not survive. In fact, and I was there to witness this happen. And this person is filthy rich, very wealthy. But that person is gone. What has happened to all the wealth? So I feel that as a people, we have a role to play in supporting, however small it may be, in supporting government to do the best so long as this pandemic is concerned. So one of the things I noticed at a point in time was that feeding, for instance, was a challenge because the institutions were, of course, running out of cash to feed frontline workers and frontline workers at the various hospitals. So, in fact, I think whilst I was at UGMC, I opted to feed the frontline workers at Building 5 for a couple of days, I think 3-4 days, both lunch and supper. But then when I came out, I had a conviction that, look, one could do it better and more, and even more impactful. And I took an inspiration from a quote that says, if you do not come out of your life experience without overflowing grace, then it all has been a waste. You have not really lived. You are just part of a coast, unquote. So that is where the inspiration is coming from. And I thought that, what can I do to impact on the lives of these frontline workers to make their lives even better, boost their morale, show appreciation of their selflessness. So I initiated an intervention, and I called it the Green Gratitude. Of course, green represents life. We also know that generally nurses and doctors also work. And I started asking friends to support me to start, first of all, with UGMC, to start feeding the nurses and doctors, the friends and corporate bodies, corporate citizens alike have been so gracious in supporting this initiative, such that on last Wednesday, we launched it and we've started feeding them. Over the next 5 weeks, we'll be providing them meals at UGMC. It's our intention to solicit more funds and support from public and corporate bodies to extend it to other institutions, other isolation centers, Ghana East, AMUAH, I'm told there's one at Kasua, and even beyond Accra. Just to show that to demonstrate that Ghanaians appreciate the efforts of our frontline workers. So essentially, that is what Green Gratitude stands for. And we hope that with the support of people like you and the general public, we can also make an impact. Mind you, anybody at all can be exposed to this situation. And we should start not to be thinking about ourselves, but to be thinking about other people and how we can make other people's life better. So essentially, that is why I've started this foundation.
Thank you very much, Russell. And I'm sure the health frontline workers all over the country and at UGMT in particular would appreciate what you're doing to support. I want to come to you, Adebayo. We're wrapping up in less than 5 minutes. What would be your final comments?
Thank you very much, Israel, and the rest of the participants. I think this has been very insightful. And just to leverage on what Rosal has just said now, I think providing this support structure is very important. You know, just like he is doing now, we just need to look at it. It doesn't have to be something, you know, highly out of place or highly expensive. You know, just a little effort that anybody could put in place to actually provide the support structure. We mentioned the issue of communication. Let's keep communicating. Let's keep telling people, just like Dr. Kaba said as well. Some people still believe that if I get to my village or my traditional people, they can just give me something. You know, this is not for the people in the local areas. So support structure is very important. Then again, you know, in terms of affordability, there are people that are living below the poverty line. We're talking about face masks. Some people, you know, it might look so trivial. Some of them could not even afford to get this face mask. Some of them will have one face mask and they will use it for like 3 weeks, 4 weeks, 1 month. You know, what is the risk? So what exactly can we begin to do in terms of awareness, in terms of providing the support structure, and also helping people on the street to understand that you need to protect yourself, you need to protect the community, and you need to also protect the economy as a whole, that is the country, so that we can make the work environment, the country, safe for every one of us. Thank you very much.
All right, thank you very much. And where can we obtain your book?
Yes, the book is available on Amazon. It's also available on Barnes and Nobles. And also you can, if you go to Auto House bookstore, you will get it there. So it's available globally, and I will encourage everyone to just try and grab a copy and see what insights you could use to leverage on these situations that we're all going through.
All right, I come to you, Noella, with your wrap-up comments. I mean, you've shared so much with us, and I think Rwanda indeed is a great example when it comes to managing COVID, the COVID pandemic. What would be your final parting words?
Thank you. So beyond what we've talked about in terms of enforcing measures and just making sure that there's a contingency plan in place, early action is quite important, whether it's preparedness or ensuring that you don't have a surge in cases, enforcing public health measures that we've talked about to lower the risk, face mask, hand washing, physical distancing, and then having a test, trace, and isolate strategy in place. So as you observe, this is at a community level, but it really will also help at the workplace level to be able to have these measures in place, and really understanding that we are in a learning phase. We are still learning about the transmission dynamics. We are still learning about what it takes to mitigate and stop the spread of COVID. So having that adaptability at whether you're developing guidelines or ensuring that they are full, have a part to play. It's very important for me to not only protect myself, but protect others. So being able to understand that we have a role to play, each and every one of us.
All right, thank you very much, Noella. Now to you, Dr. Kaba. One of the things you said that everybody is, I believe, is going away with has to do with the fact that don't think that you're protecting just yourself. If you protect yourself and your houseboy or security man is not protected, you're not safe. Any other gems you want to leave us with? Hello, Doc. Doc, it appears you would have.
Hello, can you hear me?
Okay,
yeah. I said it started with one person, and today all of us, we are paying the heavy price of restrictions, lockdowns, economic challenges, and all that. So it simply means that COVID-19 is everybody's business. We cannot leave even one single person behind. So all what we got to do is that everybody, the individual level, has to do his best, and that is the only way we can combat this COVID-19 disease, and the only way we can get it out of our way. That individual responsibility is very, very important. Thank you.
All right, thank you very much to all of you for taking part or being part of this panel. I believe it's been quite insightful, and I just quickly want to say thank you to all of you and mention you by name. We have Noella joining us from Rwanda, where she's a strategic advisor at the Rwanda Biomedical Center, and then Dr. Kaba from Ghana, consultant neurosurgeon and public health physician. He's a director of Institutional Care Division of Ghana Health Service and COVID-19 Case Management Lead and Deputy National Case Management Coordinator. Dr. Hazel, BERRARD AMUAH, an HR and business strategy expert and regional director, Palm Milk West Africa, was with us earlier. She's had to leave. And then from Nigeria, Adebayo AKINLOYE, Director, Global Talent Solutions and author of Talent Management Agenda in a post-COVID-19 world. And then our very other important guests, Russell Banful, who runs an advertising agency in Ghana called Brandflow Limited. And he has been sharing with us his battle with COVID-19 and how he survived. Thank you to you all for making this possible and to you all for watching online. Have a great day and do stay safe from COVID-19. Thank you.
Thank you so very much, Israel, and do stay safe. You're doing a great job, and I hope we will continue doing that for our country and mankind. God bless you.
Thank you. God bless you too.
Thank you, everyone.
Right. Bye.
Thank you. Let's stay safe.
Yes.